evening and welcome to Innovations in Breast Oncology. Tonight, we are going to be entertained by two of our medical oncologists at the Moffitt Cancer Center of the Breast Oncology Department. Dr. Ricardo Costa is going to talk about some exciting advances in immunotherapy for triple-negative breast cancer. And Dr. Tracey O'Connor is going to speak about improving the clinical outcomes and mitigating some of the effects of our treatments on performance in patients with breast cancer that are getting treated with various types of therapies. So we have an exciting lineup. I do have to start by reminding you that the content of this webinar is not intended to be medical advice, and the viewers should consult their physicians should they have any questions. The viewer should not rely on information contained in this presentation or webinar for immediate or urgent medical needs. Additionally, if you think you may have a medical emergency, call your physician, go to the nearest emergency department, or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation or webinar. So I want to again welcome all of you. I see there's still individuals joining us. I wanted to just point out something to begin with. And what I wanted to show you is this is a 45-year-old female who was diagnosed with HER2 positive breast cancer. And this is her PET scan showing a very large tumor in her left breast and multiple lymph nodes, including in her neck and chest and under her armpit, that are part of or why this patient would be called stage 4 breast cancer. And she's told that she's incurable because when breast cancer spreads to distant sites, it's often not curable. We offered her an opportunity to participate in her own personalized clinical trial at Moffitt and treated her with a specialized immunotherapy made from her own white cells that we injected directly into this tumor for 6 weeks with a couple of systemic antibodies, one called Herceptin and one called Perjeta. To have a lumpectomy performed, which demonstrated just a small amount of residual breast cancer that was not even HER2 positive, it was ER positive. So I put this up for you to show you the power of what immunotherapy can do for patients with breast cancer. And as a segue to our first speaker tonight, Dr. Ricardo Costa is going to discuss with you how immune therapy is impacting in a big way triple-negative breast cancer, a breast cancer that does not have estrogen, progesterone, or HER2 receptors, and is often considered a very aggressive breast cancer. He's going to show you tonight how immunotherapy can impact this tumor. Ricardo?
Thank you very much, Dr. Czerniecki. I hope everybody can see me and hear me okay. And thank you for sharing that case with us. I think the patient probably did not have a lot of toxicities from the immune therapies given to her, which again, I'm going to use that comment as a segue to the title of my talk, which has to do with immune therapy. And just staying true to the basics, immune therapy has to do with trying to unburden the patient from the well-known toxicities and severe ones from chemotherapy, especially when we treat patients for an aggressive subset of breast cancers such as triple negative. And of course, treatment of the disease with hopes for cure. So immune therapy is very fitting when we want to really effectively treat the patient in maximizing the efficacy against the cancer, but at the same time, protecting the patient from the toxicities from chemotherapy. Next slide, please. So having said that, for patients with early stage triple negative breast cancer, again, this type of tumor that does not harbor any targets that we can leverage, we offer patients a regimen that comes from a study called Keynote 522. So if anyone listening to us knows of someone or had the experience of having perioperative chemotherapy for this type of cancer, probably heard this, this name for this study, Keynote 522. And we give chemo for 6 months before surgery. 4 types of chemotherapies are given, including carboplatin, paclitaxel, adriamycin, also called the red devil, and cyclophosphamide. So for 6 months, patients have to go through all the challenges of undergoing chemotherapy in combination on top of that of treatment with pembrolizumab, which is a form of FDA-approved immune therapy with a very specific mechanism, very specific one that we'll describe in a few seconds or minutes. And then they go for surgery with hopes that, they had very good response to therapy and have eliminated the cancer under the microscope. That probability hovers around 60% with this very intense neoadjuvant program, as we say, all this chemotherapy before surgery. So 60% patients would have elimination of cancer under the microscope. Next slide, please. So as I mentioned, when we talk about pembrolizumab, this agent, which is FDA approved again, has a very specific mechanism, which is activation of this very specific type of cells called CD8 lymphocytes. But immune therapy covers a wide range of, methodologies and mechanisms of action. At Moffitt, we focus on these cells that they present antigens to the immune system as a whole. We call these cells antigen-presenting cells, more specifically dendritic cells, which is what Dr. Czerniecki pointed out on his second slide today. So we're focusing on that specific type of cell. There are other ones such as CD4 T cells that we're beginning to leverage them against cancer, NK cells as well, that we're trying to learn more about this complex part of our body, which is the immune system, which is very broad. Next slide, please. So the story with these antigen-presenting cells, and I'm going to refer to them as DCs or dendritic cells, they recognize fragments of particles or proteins that could be overexpressed by cancer cells, such as HER2 or HER3. Some cancer cells express things that we don't even know how to leverage, such as EGFR. But the idea is this: these DC cells or antigen-presenting cells, they collect these fragments from the tumor microenvironment, and they present these cells to other subsets of immune cells in the patient's body and the tumor microenvironment. And what is so exciting about the DC program at Moffitt, and we kind of depict this with this slide, don't focus too much on all the names of the cells, but is that the dendritic cells, they interact with a wide array of cells in the immune system. So one has a much broader activation of the immune system with these cells, as opposed to more specific treatments such as pembrolizumab, which is, again, FDA approved and used in clinic. Next slide, please. So what happens is this: patients come to Moffitt, they undergo a procedure to collect immune cells called leukapheresis. And these cells, they are sent to the lab through a very sophisticated and very specific cell therapy processes, everything overseen and led by Dr. Czerniecki's lab and his team. So a lot of smart people behind the scenes interacting with us in clinic. These cells are then primed, the patient cells are primed against these immunogenic peptides. And then we inject it back into the tumor itself. So this is immune therapy in a very specific, enthusiastic way because it activates the immune system broadly. And it is personalized. You're not getting someone else's cells. These would be the patient's cells that's injected back into the patient's tumor. This is what we're all about here at Moffitt. Next slide, please. And this is what we have been doing for this early phase study of 24 patients that we named the Decipher trial. We built upon what we already do, which is that Keynote 522 program, and we added vaccines injected to the tumor. Again, the patient comes into the hospital, gets the leukapheresis, and we prime these cells against these HER2 and HER3 peptides, and we inject it back into the tumor before they start chemo with the approved immune therapy, and while they're getting that for a couple of weeks. And then patients receive this standard chemotherapy, and they go for surgery. And again, the hope would be that we would accomplish good results in terms of efficacy or tumor shrinkage, better said, disappearance, with low toxicity rates. So let's take a look into what we accomplished thus far. Let's go over the next slide, please. And that's when we see that we already presented this at a major breast cancer meeting in Texas that takes place every December, brings people from all over the world. And we see that these vaccines are very, very, they're much easier compared to chemotherapy and compared to pembrolizumab. Patients, they would present at most headaches. And when I say grade 1, let me translate that. This would be mild headache that could happen, much like when patients are getting any vaccine. I myself, when I had the COVID shot, I had a lot of fever and malaise, so these things can happen. But sounds like my patients do better with this than what I did with the COVID shot. There are some chills, all low grade, so easy to alleviate with Tylenol and remediate that. And fatigue is also short-lived. We have seen a little bit of fever, but also low grade, and nausea that was very transient. And the obvious, some patients have pain because you're getting a shot into the breast tumor. So I think this slide epitomizes and keeps us very excited that yes, we're able to spare patients from the burdens of more aggressive therapies with the dendritic cells treatment. So we know this is really, really important, as it of course behooves us to treat patients to shrink tumor, but also most very importantly, to keep the quality of life and the low risk for the treatments that are being developed. Next slide, please. Yes, I didn't build a slide. Dr. Czerniecki might be upset with me now, disclosing the efficacy so far, as of course we looked into it, but this is still unpublished data in terms of the complete response rates that we saw in this early phase study. Suffice it to say that we're very enthusiastic. The response rates have been very good. I think my smile already gives away that the number was high. And this, of course, makes us look into the future with excitement. I'm using his word again. And we're going to be looking into the preliminary results with enthusiasm and publish this. This has been submitted for presentation in a major cancer meeting for this December. And we'll proceed with final analyses. And very importantly, we'll look into all the correlative analysis because we collected blood and tumor tissue from these patients to learn more about the mechanics as to why and how can we even improve what's already showing to be so good. We're continuously applying for funding for more opportunities as we see that the dendritic cells are a very enthusiastic platform that's helping patients already in these clinical trials. More immediately, actually, this submission took place today. we submitted for an amendment of the study to treat patients with even higher dosages of these vaccines in this trial. So hopefully in the next few months, we'll be able to enroll even more patients in the Decipher trial. And there are many more ideas coming from the lab at Moffitt or Dr. Czerniecki's lab. I just have a little curve there, which is exactly what he saw in the lab first when he treated cancer or mice with alpha-gal seer to modulate the activity of these dendritic cells. And for that one patient that he described to us, we already saw benefit with the dendritic cells combined with monoclonal antibodies for HER2-positive disease. So we are at the cutting edge. This is why I work at Moffitt, because I want to participate in this environment of cutting-edge immune therapy, which is really exciting, and we hope that we'll share many good news in the near future with all of you. So with that, I think I will close and pass it to Dr. Czerniecki. And thank you for your attention.
Thank you, Ricardo. Very exciting results. For people online, we're going to have another presentation yet. Text your friends, tell them to come on and listen. And there's an exciting Q&A left at the end. You can ask Dr. Costa all the immunotherapy questions you want to. Our next presentation is by Tracey O'Connor, and she's going to discuss a little bit about exercise and improving and making you stronger while you're going through treatments for cancer. And this is a really exciting area of oncology. As Dr. Costa alluded to in his presentation, chemotherapy and some of these therapies take a toll on our physiology and our bodies, and people are actually getting to the point where they're incorporating things like exercise and healthy living and wellness into our treatments, and people are having much better outcomes on the other side. So I'm going to introduce Dr. Tracey O'Connor, who's also one of our breast medical oncologists here at Moffitt Cancer Center. And she's going to discuss with you stronger survivors, innovations in improving patient outcomes. Tracey.
Thank you so much for that kind introduction. It's nice to be here this evening. The first project I wanted to discuss really builds on what Dr. Costa was talking about, and it's a study we've been working on for a while and are applying for funding. This is looking at neoadjuvant HER2-directed dendritic cell immunotherapy in combination without any chemotherapy, but just with a monoclonal antibody targeting HER2, trastuzumab, as a de-escalation strategy for our older adults with HER2-positive breast cancer. Next slide, please. So just for some background, breast cancer incidence is high in older patients, with about 45% of all breast cancer diagnosed in women who are 65 and older. And we expect the proportion of new breast cancers in women who are 70 and older to continue to increase. And the prevalence of HER2-positive breast cancer in the older patient is only marginally lower than the 15 to 20% in younger patients. About 10 to 15% of breast cancer patients over 65 have HER2-positive tumors. And this little cartoon at the bottom is just to show you what a non-HER2 positive breast cancer cell looks like in terms of the amount of HER2 receptor and gene present in the nucleus compared to a HER2 positive cell where there's much more to target. Next slide, please. One of the things that's really key for us in the clinic when we go to take care of our older patients is to recognize that it is important to try to treat people not by their chronologic age, but by how they're functioning. So in other words, 75-year-olds can look very different from one another, where many of them can be very fit and functional, but there are those that are vulnerable and those that are frail. And those are patients we have to be particularly careful about when we're thinking about delivering anti-cancer therapy. Next slide. So in background, our usual therapy for HER2-positive breast cancer when we're treating people prior to surgery is a combination of chemotherapy, taxotere and carboplatin, and two monoclonal antibodies, trastuzumab and pertuzumab. And this targeted therapy has dramatically improved patient outcomes in HER2-positive early breast cancer. But we have a problem, and that's the increased risk of toxicity in our older patients who experience double the risk of chemotherapy-related hospitalization, increased hematologic toxicity in terms of having a low white blood cell count or developing anemia. They can also be at increased risk of dehydration from diarrhea. And this population in particular needs well-tolerated and efficacious regimens for HER2-positive breast cancer. Next slide. And one of the reasons for this is that we know that when we treat older patients with breast cancer, if you look at a highly resilient, fit individual, the top line, the top dotted line, they may have a little dip in their function as a result of cancer therapy, but they rapidly go back to their baseline and they're able to stay there. Whereas other patients that we treat who may be more vulnerable or frail will have a dip in their function and never quite get back to their baselines, or worst of all, become frail as a result of the side effects of the therapy we administer. Next slide. So in a very exciting study design, we're looking at DC immunotherapy as a neoadjuvant therapy for patients with HER2-positive breast cancer who are older. They'll receive an intratumoral injection weekly, weeks 1 through 6, and on week 10 and 13. And they'll also just receive the trastuzumab alone, which is remarkably well tolerated. And we're going to give that every 3 weeks without any chemotherapy and without any pertuzumab, which can cause diarrhea. And then patients from there can go to surgery. Next slide. Another project I wanted to highlight is one that I've been working on for a while, and it's a topic called respiratory muscle training, which I'll explain in a minute. And we're looking to improve quality of life and fatigue in patients older than 70, so-called metavivors, with metastatic hormone receptor positive HER2 negative breast cancer who are being treated on first-line therapy with a group of drugs called CD4/6 inhibitors. These are medicines that you're commonly seeing on TV like Verzenio or Kisqali, or common ones that you'll see advertised, and they're widely used. I'm often asked what a metavivor is, and the reality is that advances in our cancer treatment have significantly improved survival with incurable breast cancer, leading to a growing population of metavivors. These are individuals living with metastatic breast cancer as a chronic illness. Next slide. The big problem that we see these days is the amount of fatigue that women with metastatic breast cancer are experiencing. So up to 86,000 women in the United States are diagnosed with metastatic breast cancer every year. About 75% of those individuals are eligible to be treated with the CDK4/6 inhibitors, but about 70% of those patients, when they receive the treatment, report fatigue, which can be quite debilitating. Next slide. So when you talk to the patients, cancer-related fatigue is different than regular fatigue in that it doesn't get better with rest. So patients will describe fatigue where they just cannot get out of bed, feel that they can't commit to any kind of appointment or invitation because they just don't know how they're going to feel at any given moment. And this can also be, very disruptive to their personal lives, work lives, affect their quality of life. Next slide. So respiratory muscle training is being developed as a way to try to mitigate some of these side effects. The CDK4/6 inhibitors have side effects like fatigue, shortness of breath, and reduced functional capacity. Now, the gold standard to try to address these treatments is exercise. But actually, most patients are inactive during their treatment, and really only like 5 to 10% actually meet the exercise guidelines, which is probably also true for their doctors. Home-based respiratory muscle training may be an innovative non-exercise strategy for metastatic breast cancer patients. It involves minimal cost, minimal effort, little supervision. And for the patients, it's fast, it's easy to do, and it's completely safe. Next slide. So it was brought to my attention by one of my colleagues at Roswell Park, Dr. Andrew Ray, who had actually used respiratory muscle training to help train Navy SEALs to have better performance during a lot of the very intense training that they do. And it's basically training your inspiratory muscles. And when you train your inspiratory muscles, sort of like a dumbbell for your diaphragm, you're becoming stronger. Breathing becomes easier. You use less muscle work. You actually improve the amount of oxygen you take into the bloodstream, and you have less fatigue people have better function and feeling. Next slide. The device itself is really simple. It's just a scuba mouthpiece and resistance valves that can be adjusted to make the breathing more difficult for the patient, the training more difficult for the individual over time. There's good precision and control of the resistance, and it can be washed and cleaned in between patients if necessary. Next slide. Our clinical trial proposal is a 2-arm home-based randomized pilot trial of respiratory muscle training for older patients with metastatic breast cancer who are receiving a CDK4/6 inhibitor. And we're looking to have 60 patients randomized 1-to-1 to either a 12-week respiratory muscle training intervention or a usual care control. We're going to ask them to perform respiratory muscle training 5 days per week, 3 weeks of 15, or a total of 45 breaths per day, with optional virtual supervision if they would like. And our theory is that the respiratory muscle training will increase the respiratory muscle strength of the individuals, improve their functional capacity, which will mean the amount of time it takes them to walk a 6-minute walk test is going to get, they're going to get faster and better and stronger, decrease their fatigue, and increase their quality of life. Next slide. I wanted to highlight a couple of other studies that are ongoing here at Moffitt that are, looking for funding, looking for patients. One of my colleagues in health outcomes and behaviors, Dr. Heather Jim, is looking at cognitive behavioral therapy for fatigue among women with metastatic breast cancer. Next slide. This is called Energize MBC, and it's a cognitive behavioral therapy model of fatigue. So again, when we talk about the vicious cycle of cancer-related fatigue, is that people believe they need increased rest, but when they rest more, they become more deconditioned, which actually worsens their fatigue. So this is actually a platform on the web that helps patients with goal setting, learning how to pace themselves, giving sleep hygiene tips and helping to improve their sleep, helping them with their mental game, building teams, keeping worry in check, and trying to stay energized. Next slide. The platform itself is on a website, and it is very interactive, allows people to set goals, get feedback on how they're doing, and have the ability to chart things over time. Next slide. In a previous study, they've seen significant improvements in fatigue from 28% to 73% with the intervention. Pardon me, next slide. And they're looking to adapt this platform to the needs of women with metastatic breast cancer who are treated with the CDK4/6 inhibitor. It's going to be called Energize MBC. They're going to refine and finalize the platform and test the feasibility, acceptability, and efficacy via a pilot randomized controlled trial. Next slide. My colleague Nate Parker has been working on a very fun project called Project Rally. This is a YMCA-based pickleball program for cancer survivors. And we're building on a program feasibility and acceptability from a recent pilot study that was made of 55% breast cancer survivors. We're going to look to test the effects of a 6-month pickleball intervention program on fitness and health-related quality of life in a randomized waitlist controlled trial. And the innovative part of this trial is that we're working through research partnerships with 2 YMCA branches so that this program can be delivered across 4 different centers, looking at barriers and opportunities for scaling up and sustaining the program over time. And with that, I'm end.
Thank you, Tracey.
You're welcome.
I am sure there are going to be a lot of questions about some of this exercise studies that you have. Before we go on into the question and answer period, I want to introduce Janet Carmelo, who is our foundation partner and helps us raise funds to conduct some of these interesting clinical trials that you've heard about this evening. Janet has been with Moffitt for several years now, and she's been a big partner with the breast department to help us achieve many of the goals that have benefited some of these patients, including the one I showed you originally that was treated with her own clinical trial. So, Janet, the floor is yours.
Well, thank you, Dr. Czerniecki, and hello, everyone. In just a minute, we will return to have the question and answer portion of our webinar. I want to thank you for your time this evening. We all have busy lives, and there are so many things that you could be doing on this Thursday night, but you chose to be here with us, and we are truly grateful for it. I want to thank Dr. Czerniecki, Dr. Costa, and Dr. O'Connor for working late tonight and providing such good insight. Also, I want to thank my colleagues, Brielle Humphreys and Stacy Price, for managing this webinar behind the scenes tonight. The expert doctors we heard from tonight not only benefit local patients, but their work really has global impact. Our Breast Cancer Center of Excellence has several groundbreaking clinical trials that are made possible by the philanthropy of our supporters. And there, you heard about just a few of these exciting breakthroughs that they are working on tonight. If you have an interest in exploring ways you can provide philanthropic support for this important work, please contact me at your convenience. Thank you again for joining us. And now I'll turn it back over to Dr. Czerniecki for the question and answer section. Dr. Czerniecki?
Thank you, Janet. I'm going to bring back in Drs. O'Connor and Costa. If you have questions, you can put them in the question and answer text, and I'll read these questions and direct them toward one of our panelists here. We'll start with the first one, and I'll direct this one toward Dr. Costa. What immunotherapy is available for metastatic hormone receptor positive HER2 breast cancer?
Yes. So thank you for the question, because indeed I would expand by answering and saying that we treat every subset of breast cancer differently, and the activity of new agents will be different depending on the subset of the breast cancer that we are trying to apply that new therapy to. So for the immune therapies that are directed again to the immune system, we have none approved now for hormone receptor positive breast cancer. I don't want you to get the notion of antibody drug conjugates confused with immune therapy. The antibody drug conjugates that are out there, and again, antibodies, a form of immune therapy, is a molecule that carries chemotherapy moieties that target the breast cancer cells themselves. So there are antibody drug conjugates approved for hormone receptor positive breast cancer. And one of them would be sacituzumab govitecan, Dato-DXd more recently, and also T-DXd or Enhertu. But going back to what I think the question was, what are the strategies out there that could activate the immune system per se? We don't have anything available in the clinic. We do have efforts though in the space of the early phase clinical trials, right? And many of them. At Moffitt, I could highlight the work of my colleague, Dr. Soyano, who is developing the dendritic cells vaccines for patients with a very specific situation when they have hormone receptor positive breast cancer. And that's for those with metastatic disease that have a tumor that harbor what we call an ESR1 mutation, which is a mutation that we see at times in 40% of the cases when the cancer becomes refractory to endocrine therapy. So she's priming the immune system against these mutations for patients with tumors that harbor the ESR1 mutation in hopes to accentuate the efficacy of an oral agent called elacestrant, which aims to block ESR1 positive cells. So there's nothing in terms of immune therapy available in the clinic now, but there are efforts and development, and Moffitt is part of that. I think the question was for metastatic disease only, right, Dr. Czerniecki? If I remember.
Yes, yes. And I will add that we are feverishly working with several models in the laboratory that we're using for what we call luminal B type estrogen positive tumors with immunotherapy. I believe in the next year we will have several other new trials for hormone positive breast cancer in the space of immunotherapy. And that brings us to the next question from Jane Williams, and I'm going to direct this one to Tracey since we've been talking about this all day. Are there any trials or advances in immunotherapy for hormone positive breast cancer, especially for lobular breast cancer?
Well, just as we were talking right now, these things are under development. Dr. Czerniecki presented an idea actually just yesterday evening to me of looking at expanding the vaccine program to the DC immunotherapy to patients with lobular carcinoma who are being treated prior to their surgery with either anti-estrogen therapy in some cases or IV chemotherapy in the smaller subset of patients with lobular carcinoma that actually benefit from chemotherapy. So I would say that that's a work in progress. There certainly is not currently a standard if the cancer is estrogen receptor positive, as many of them are. But as he just mentioned, he's working in the lab very hard, and we're working to try to translate that to the clinic.
Thank you. All right. The questions are pouring in, so I'm going to skip around a bit here. Dr. Costa, you said that the cancer tumor can be injected, but what if the cancer cells are scattered and not contained in one spot or one tumor?
Yeah. So, of course, I'm assuming that the question still pertains to patients with early stage breast cancer, right? But the idea that I would also try to make clear is that when we inject these cells, and again, we're injecting immune cells, and I hope to have articulated the point with my slide, that they activate with other immune cells, many different ones. NK cell, I'm just going to name a few just for discussion's sake. NK cells, CD8, CD4 positive cells. So it's not necessary that the dendritic cells, the vaccine, would interact directly with every single cancer cell in that area, because there will be spread of the immune response as one cell, quote unquote, talks to the other, and we would see response that way. So this is why I don't know that we get too concerned about making sure that every single area of the tumor in the breast gets exposed to the vaccine. But let me add more to that question, which I think is a very good one, because I alluded to a study that is for patients with metastatic disease, right? And there are other studies at Moffitt in which we inject patients with the vaccine when the tumor is not even there. The tumor was taken out already, but there is a risk of the cancer coming back, which begs the question, where do we inject the tumor? Well, you don't necessarily need to inject the tumor. There are structures in the body called lymph nodes that we all have, which are populated by immune cells. And via ultrasound-guided shot, we can also stimulate the immune system by injecting the lymph node itself. So there are ways, of course, we favor doing the intratumoral injections when possible, but there are ways to stimulate the immune system with our platform at Moffitt that does not require direct contact with the vaccines and the cancer cells.
Thank you. I'm going to direct this one toward Tracey. Does the fatigue technique also apply to stage 4 non-small cell lung cancer patients who are using Keytruda? My husband is exhausted all the time.
Oh, that's such a hard thing. I think that you will find that the fatigue techniques work for any kind of cancer-related fatigue, regardless of the primary. So it's definitely worth looking into. There is a patient-facing NCCN guideline on fatigue that's available to patients that gives really good advice on ways to reduce fatigue, such as if he's not really able to exercise, even being present in nature, spending time out of doors. There's other things that you can do as well, in addition to sleep hygiene, that can really be helpful for patients.
Stay on, Tracy. Have you found
Okay.
Pilates to be helpful for patients who are 65 or older? And do you see Pilates as helpful for building muscle to alleviate becoming frail?
I think Pilates is excellent exercise as medicine because it does both build muscle and core strength and works on flexibility. And those are things that we definitely lose as we age. So I think Pilates can be an excellent intervention for patients looking to get stronger and keep their strength.
And then a related question, actually, how can information about the respiratory muscle device be shared with current patients or newly diagnosed breast cancers that fit the criteria?
Well, I'm just so excited that people are interested and think it's a good idea because I'm very enthusiastic about it. We're applying for funding at the end of August. Hopefully, we will get it, and then we'll be opening a clinical trial, and I'll try to promote it through all of the Moffitt channels to reach as many patients that are interested as possible.
All right, let's go on and ask Dr. Costa the next question. Can the HER2 positive vaccine be used to prevent recurrence if I was diagnosed with HER2 breast cancer in 2018 and was treated with trastuzumab with success by Dr. Costa?
That sounds like the patient knows me. This is a very good question, and
It's a softball.
yeah. But anyways, this is a very good question, which has to do with the kinetics of the immune system across time, right? And of course, what is the best way to monitor for breast cancer recurrence? And all these two questions. I mean, these two questions are really they have not been answered, right? But for someone that in 18 had a good response to neoadjuvant HER2 positive disease, and let me define that a little bit. The patient received the chemo with the HER2 antibodies, which was the standard then and continues to be now, and had complete elimination of the cancer. I don't know that we would have a way to select this patient for a vaccine study now. It seems far from that window in which we would be looking for patients for studies. There are studies, though, at Moffitt included, and in which we treat patients with HER2 positive disease, which doesn't have to do with my talk. I'm stepping outside now. That's okay. That have higher risk of recurrence. Those patients that receive the chemotherapy and they have residual cancer in the breast or lymph nodes, because it behooves us to intensify things in hopes to prevent recurrence when HER2 positive disease, when recurs, is very serious. So in that scenario, we usually have a window of 6 to 12 months to offer the patient vaccines, because you want to prime the immune system the sooner the better in hopes to eliminate any microscopic, invisible residual foci of breast cancer.
Yeah, I'll add to that. Dr. Hahn actually conducted a multi-center trial in that exact population, given for people who had residual disease if they had standard HER2-directed therapy. And the survival rate for patients that were given either one of two vaccines is around 96, 97% at 5 and 6 years. So it appears that even in the high risk setting, these kind of vaccines can be beneficial to patients with HER2, breast cancer, and maybe also triple negative. We do have one open trial with vaccines currently at Moffitt for patients that are HER2 that have residual disease after standard therapy. And we also have one being conducted in triple negative by Dr. Solomon, who's giving personalized vaccines using the dendritic cells for patients that have residual disease after that keynote regimen that Dr. Costa mentioned before, to try to prevent them from developing metastatic disease. That trial is ongoing. If somebody's in that situation, they can contact Moffitt's breast department to inquire about that. Okay, let's ask Tracey, do you have a recommendation on the diet for breast cancer patients?
So the diet that I talk to my patients most about, that we think about being healthy for having a history of breast cancer, is a diet that's low in saturated animal fat and very high in fruits and vegetables. It's something along the line of a Mediterranean style diet, I think can be easier for patients to adopt and adhere to. It's important to try to, in addition to the dietary contents, to try to maintain a normal BMI or body weight after diagnosis and in survivorship, because that is definitely correlated with good outcomes. So eating a healthy diet, staying as active as possible, and trying to maintain a healthy BMI are all important interventions for survivors.
All right. Let's get to this question. Loretta Robinson, have the researchers found an additional difficulty in identifying funding for clinical trials or research under the current administration? So I'll answer that. The answer is it's pretty difficult even before the current administration to get funding from the federal government through either the Department of Defense or the National Cancer Institute. That number hasn't reduced significantly, but it's still very difficult for patients or our researchers to do that. We sometimes depend on philanthropy to get a trial started, and once people see that it's working, then it's the government will throw in and give grants because they have a hint that something's working. So early philanthropy can really enhance our ability to get clinical trials going. Let's see, we had this one. Immunotherapy, I think I mentioned this one. Is immunotherapy treatment available for triple negative patients who already had a lumpectomy, chemo, radiation? Can it be used to prevent recurrence? I did kind of touch on that with Dr. Solomon's trial. It's applicable for those who have residual disease. Tracey, how about this one? Are there any clinical trials being offered for stage 4 bone invasive ductal carcinoma that's ERPR positive, HER2 negative?
Yeah, actually, here at Moffitt, we've got a pretty broad array of clinical trials for hormone receptor positive breast cancer that has spread to other sites, investigating new agents, new combination of agents, and lots of things that are available. So if that is something that interests you, then the way to go about that would be to probably schedule a consult and come in and we can review what is available on the, at the current time on our clinical trials portfolio.
Here's a different question. Or I assume this means, what does this group think about advancement of blood marker tests as a way to catch recurrence as quickly as possible? And is there treatment recommendations if something shows on blood marker tests but not scans? You can each comment on that one.
Should I go
Ricardo, do you
first?
want to go first, or?
Yes, sure.
I think this is an area where, science, as often can happen, has advanced beyond what we do practically in the clinic or what we know how to do. And it's a mixed bag. I mean, certainly we can order a Signatera test looking for circulating DNA in a patient who's been treated for breast cancer. The problem is once we get that result, if it is positive, and we do scans and we don't find any evidence of disease, we don't know that doing an intervention at that point is going to make a difference. So then that can be a very high anxiety situation for a patient as we continue on with scans. Also, in trials up to now, when we have done studies looking at routine scanning of patients looking for metastatic disease, there's not been an indication that diagnosing metastatic disease earlier by doing a scan all of the time rather than waiting for a patient to tell us a symptom and then we order a scan, that's never been proven to help people live longer or better after a diagnosis of breast cancer. So I will sometimes do these testings based on discussion with patients, but I always caution that we often don't know what to do with the result. I think many people want to test because they think it's going to make them feel better and be reassuring. And the problem is it doesn't always happen that way. Sometimes tests can actually make us more anxious and feel worse. So it's just important to have a very thorough conversation with your treating doctor.
Yes, I agree with everything you said, and I understand the frustration. We get this question all the time, and I clearly face it, right? We come from this paradox of sorts in which we want to hurry up to treat the patient, then we wait. In breast oncology, we abide by the guidelines, which are true in the US and across the Atlantic. So both ESMO, NCCN, ASCO would say just examine the patient, don't order any blood work, tumor markers, imaging studies based on the data coming from the mid-90s, because it never showed survival benefits. So more recently, we have liquid biopsies, right, which have shown to be prognostic. And we think in those terms, we met-ons, and meaning that if you test positive, there's a higher chance of the cancer coming back. However, we don't yet have the clinical utility for prediction of benefit to therapy. So we don't know what to do with a positive test in the sense that, what do? Do you treat the patient at that point? Is it going to lead to overall improvement in outcome or not? And what Tracey alluded to, it's, the emotion of fear and the anxiety of having that test positive and the physician not knowing how to guide the patient is detrimental. I think, it must be very difficult to be in that situation. So it requires a lot of discussion if one decides to have a test done before we embark into that, because you could jump through a rabbit hole of a lot of uncertainties.
I will make a push for a trial that we have open for people having surgery there, and that is to actually look in the bone marrow or take a small blood sample of the bone marrow to look for cancer cells in the bone marrow that we may use to find some information about what governs how cancer cells can lay dormant for years and then recur. So if you have the opportunity to, or you're going to surgery at Moffitt, you may want to ask your provider if you can participate in that study to actually look at some of these subclinical cells that are around the body to see if we can learn more about them. Okay,
if I could add, in our studies at Moffitt, right, Dr. Czerniecki, we do collect blood to look into liquid biopsy measures and other measures of activation of the immune system. We even collected stool samples for our Decipher trial. So we pay attention to all this. We're just cautious into the translation of the findings into clinical practice and how you interpret the data and apply it thoughtfully into the clinic. But I think Moffitt is right there with science.
Here's one I get in clinic a lot. I'm a Moffitt patient and have been for 5 years. My question is, have you seen any benefit for cancer patients taking a GLP-1 medication, Mounjaro, Ozempic? Tracey?
I think that at this point in time, this is an investigational area in terms of looking at using these medicines to help people lose excess weight, maintain a healthy weight. And we hope that that will have an impact on outcomes from breast cancer. At this point in time, we just don't necessarily have that data, although we have data on body weight and maintaining a healthy weight after a diagnosis, and that is associated with better outcomes. Once people are not receiving chemotherapy, if my patients are interested in using a GLP-1, to try to help them get to a healthy weight or maintain their healthy weight, I certainly encourage them to try if that's something that they want to do. There are not many interactions with the therapies that we give and maintain, in the maintenance phase.
Okay, here we go. Let's ask Dr. Costa this one. How are you ensuring women of color are included in your trials? And I'll preface this by saying that women of color have participated in multiple of the DC studies and have had spectacular results for making their tumor go away. So we try to encourage them to participate, especially us who do surgery, to participate in some of these neoadjuvant trials. But I get the whole there's some reservations based on past research, but I would encourage all women of all races to participate in these trials because that's how we're going to get to find out if all these things benefit everyone. But Dr. Costa, can you address that? You've obviously had women of color in the Decipher trial.
Correct. I believe the number is 17% of the patients that were enrolled into this study. And I remember the number as I typed the manuscript for the abstract this past weekend. So I think as far as the strategy, it's all about that connection with the patient, building up that trust and just explaining things. And if we take the time and break down the concepts, to the level of what is it that a clinical trial means, right? It is an experiment for sure. And we have to exercise equipoise or neutrality, make sure that the patient is comfortable if she does not want to participate into the study. So it's just a matter of really talking to the patient. But I think at Moffitt, we're seeing more and more African-American women participating. One patient that I called today who's coming Monday for another clinical trial, not the Decipher trial. She's African-American, and then she's interested. So yeah, I think we're doing well there, and I would urge every provider to speak openly and make sure that you build that trust connection with patients.
Yeah, I'd add that number of 15 to 20% is way higher than the national average for participation of women of color in clinical trials. So I think we're doing some things well there to encourage that. Tracey, someone's asking, can patients with other cancers at Moffitt get into your respiratory muscle training or buy the apparatus?
I can't, or I won't be able to enroll them into this study idea, but the apparatus itself, you can purchase on Amazon, actually. I would just caution that we probably need to give you some instruction on exactly how to use it. I can't tell you what website is available, although I would imagine that instructions do come with some of the devices themselves. The picture that I showed is sort of like a homemade device that my friend Dr. Andy Ray created back at my previous institution, but there are some devices that you can purchase online.
Let's see. Is Moffitt looking at anything new, different to help prevent recurrence or promote early detection recurrence for triple negative patients who have completed Keynote 522 treatment? I think we touched on this with Dr. Solomon's trial for people who have residual disease that are at higher risk for recurrence. There's a personalized vaccine that people can get once they finish their Keynote regimen, and that is aimed at trying to reduce the risk of recurrence. Let's see, maybe one more question here. Tracey, where do I go to help regarding the exercises for fatigue? Is there a website or name of a technique?
I think that for the fatigue management, the places that I would think initially, and I should have looked this up before this discussion, but the NCCN has patient materials, and we have a fatigue committee as part of the NCCN. So I think those materials would be a very good place for patients to start. The American College of Sports Medicine, the ACSM, has very good exercise recommendations, and they have special programs for cancer patients. Your local YMCA is likely to have, especially the two that are affiliated with Moffitt, also has programming on exercise that's specific to cancer patients that I think people would find very helpful.
All right, I'm going to end on this last question. Since the immunotherapy vaccines to treat triple negative and HER2 breast cancer so well, can the chemo sometimes be skipped? And the answer to that is, yeah, there's Tracey mentioned the clinical trials she's doing in patients who are older. And another one of our medical oncologists, Heather Hahn, is also doing a clinical trial for patients with smaller, up to 3 centimeter HER2 positive breast cancers that people can skip chemotherapy if they do the immunotherapy, have surgery, and don't have any disease left. Dr. Costa in the triple negative is de-escalating the amount of chemo. He mentioned 6 months. He's working on skipping the second half of some patients if they have a good response to immunotherapy. So the answer to that is yes. There'll be much more to come of that. Maybe we'll discuss that completely next year. With that, I'd like to thank everyone for participating in this. The hour's late. I don't want to keep people longer than necessary, but the questions were great. I want to thank the participants, Dr. Costa and Dr. O'Connor, for their stimulating presentations. Remember, if you feel compelled to help support some of these clinical trials and clinical endeavors, please reach out to Janet Carmelo and the Moffitt Foundation. I bid you now a good evening and thank you for participating in this webinar. Good night and thank you.
Thank you.
Thank you.